So this is an example of a huge pneumothorax. Hopefully no one would ever miss this. This is pretty darn obvious, but let's walk through it to make sure that we have the process in mind so we don't forget it. So portable x-ray, pretty much upright. Here are the little beads. Sometimes techs will use this little bead marker, so it's pretty much an upright x-ray. It's squared well, left lung, right lung, and your eye will immediately draw you to the abnormality. And the abnormality, of course, on this film is that this is pretty black here compared to this being gray and normal. So the question that you should ask yourself is why. And if you haven't noticed yet that there's a nice pleural line right here all the way down, and this is about an 80% pneumothorax, then think about how to train your eyes so you don't miss that. So again, you want to look at symmetry. The apices look different. This one is gray because it has lung tissue markings all the way to the top. This one doesn't. So this is hyperlucent. Over here all the way down, you can see lung markings out to the periphery. You don't see any air in the costophrenic angle. You don't see any black air all around these edges. And yet this looks markedly different. And the lung is collapsed to about here all the way up. It almost looks like this person may have something else going on in here as well. I'm not sure really what that little line is. It looks too small to be a VP shunt. It may just be an artifact. But again, look at how nice and distinct that angle is. This is called a deep sulcus sign, where you see only air outlining the edge of the diaphragm with the rib cage. So this is a huge right pneumothorax. The mediastinum is shifted maybe a little bit to the left. You can see the trachea here. It hasn't really shifted a lot, so you wouldn't necessarily call this a tension pneumothorax. If this were a tension pneumothorax, the trachea would be shifted way over here, and you wouldn't see any lung markings at all over here probably. So if you're moonlighting somewhere or you get called to the floor to see someone who's become acutely short of breath or hypotensive and you get a stat x-ray because you've examined the patient and noticed that they really don't have any breath sounds on one side of their chest, then the treatment for this acutely would be to try to insert a small tube, generally in the second intercostal space in the mid-clavicular line, so it'd be about here. An IV catheter will do, and basically all you're trying to do is to allow the trapped air within the hemithorax to be vented out of the chest, so then the lung could re-expand. After you do that, that's the first thing you could do. Then you could put a chest tube in, either a small bore chest tube. Generally those would go high and anterior because you want to drain air, and a small bore chest tube, which would be a pneumothorax catheter by most vernacular, would work just fine for that. If this was a big trauma case, somebody had come in a big car wreck, you'd probably want to put a large bore chest tube in, and you might aim to put it in a couple of interspaces lower so that if there were any bleeding, say if there had been broken ribs, that you would be able to control both the air and the bleeding. There are no broken ribs on this side, so this is probably someone who just had a spontaneous pneumothorax, either from emphysema bulla bursting, or maybe they're a cocaine addict and they were doing a big hard valve salvo to get the best out of their crack cocaine. But this does not appear to be a traumatic pneumothorax. So a small catheter could be placed here acutely, and then something more definitive after that. The majority of spontaneous pneumothoraces that happen in young, healthy people are generally because they're tall and they have little bulla at the top of their lungs. The recurrence rate is pretty low, and their lifetime quality of life is not damaged by that.